Everybody, welcome back and Happy New Year. Happy 2024. I'm so glad to see so many of you braving the snow. It's crazy weather that we have in New England, you know, and welcome to those on Zoom as well. I'm just thrilled to welcome you back to our Leaders in Public Health series, our first Leaders in Public Health for 2024. As you know, the purpose of this series is to bring extraordinary public health leaders, thinkers, and doers to Yale to help expose us to new ways of thinking, teaching, studying, and most of all, practicing public health. I am beyond thrilled to welcome Carter Dredge here today. Carter is the lead futurist for SSM Health, which is, for those not familiar, a huge health system headquartered in St. Louis, Missouri, but with hospitals and kind of outposts across the country, serving over 40,000 people and communities across 4 states. At SSM Health, Carter provides strategic leadership in research and development, innovation, and in identifying new ventures to accelerate large-scale health transformation. Many of our country's largest healthcare systems have these venture arms now as a way to identify and invest in the products that are most likely to transform the way that they deliver accessible, equitable, and cost-effective care to patients, and Carter gets to lead that at SSM Health. Among other amazing accolades prior to joining SSM Health, he had leadership roles at organizations including Intermountain and elsewhere, and had worked at multiple companies dedicated to improving population health, such as home care and payment reform initiatives. He's also, and I'm sure he'll talk about this a little bit today, a founding board member of Civica RX, which, if you're not familiar with it, is one of the coolest not-for-profits in the healthcare space today. It was set up as a generic drug company to ensure that essential generic drugs are accessible to everyone through some really neat funding and partnership mechanisms. I don't want to give away all of the secrets behind it. He also sits on multiple other boards, including Navitus Health Solutions, Lumicera Health Services, and Graphite Health, which is focused on similar kind of models behind digital health. He holds a bachelor's degree in business management and corporate finance from Brigham Young, a master of healthcare administration from Cornell, where he also teaches, and will soon be receiving his doctorate in business from the University of Cambridge's Judge Business School. And correct me if I'm wrong, but you were one of the first class of kind of business executives to get to do the PhD at Cambridge, correct?
First American.
First American, which is pretty awesome. Carter is also a personal friend. He and I were in the same class of the Aspen Health Innovators Fellowship. So the Aspen Institute has this fellowship for kind of a little over a dozen national health innovators every year. We're chosen not just based off of our own kind of work in healthcare and public health innovation, but also based off of this idea that we create a mosaic of thinkers and doers who, in sitting in a room together, we both read kind of great texts and engage in deep discussions. And the idea is that we motivate each other to think more kind of grandly, but also deeply, and also to enhance our journey through transforming the American and global health system. And truly one of the greatest joys of my life has been getting to know Carter and the ways in which he thinks about the world that are in many ways very different from how I do, but are also amazingly complementary. And he has continually pushed me to think bigger and wider, and was actually part of my choice to come here in July. So with all of that, Carter, I'm thrilled to hear you talk. I'm sure that he is going to inspire all of you with his vision and strategy. And I can't wait to both hear what you have to say and to hear the questions from the audience afterwards. So welcome, Carter.
Thank you, Megan. Thank you so much, Megan. It was just a pleasure. And glad to be here with all of you. I'm really looking forward to it. You know, today we're going to talk about, for some reason my clicker is not working. This works. Not sure. While this is going here, not sure if it was just... While we're working on the clicker, a little bit, whenever I kind of meet with a group like this, a prestigious group, one of the best universities in the world, people who lead thinking, I always think about why. Why do I do what I do? Why do you do what you do? And just for a little bit for me, I grew up in a 4-generation home. My great-grandmother was born in 1899 and died at home in 1994. My grandfather was also living there. He was taking care of my mom. My mom was paralyzed in a car accident at the age of 15 years old before I was even born. And so me and my twin brother were miraculously born. And my mom had a lot of health challenges. She was homebound for over a decade. And so how I grew up was me and my twin brother, my mom who was paralyzed, my grandfather who when he retired helped take care of her and me and my twin brother, and his mom, my great-grandmother, the one born in the 1800s. Okay? That's how I grew up. And so I was surrounded by people that had a lot of health challenges. Both either, again, my grandfather died of cancer. My great-grandmother was ultimately blind. She couldn't really see, had major heart problems. And I was just surrounded by people that had massive health challenges. And I just wanted to do everything I could to figure out if we could make life a little bit better for them. And so that's where I got into healthcare early. I had an inclination towards business, but I desperately wanted to make impact for the people who had the toughest health challenges. And from talking with Dean Ranney and others, the people, you in this room, you're clearly investing time, money, effort, because you want to make it better. And I've always been so interested and so willing to engage with people who want to make it better for others. And it's just a privilege to be here today. So that's just a little bit of a backdrop. I'm preaching to the choir. Healthcare, whether it's in the form of delivery, payment, public health, all these other things, it's complicated. Okay? So I was in a meeting with Alex Azar, who I think is a Yale alum, last month in December in Washington, D.C. And, these are all these different agencies. There's this massive amount of complexity. And when you start actually thinking about other relationships beyond just regulatory, the modes of information start to look a lot like this, fast, because of how complex this industry and all these connected pieces are. We've got aging population. We got massive labor shortages where we have really pressing needs for productivity. In terms of pushing the boundaries of what's possible, there's hurdles to innovation. Going into these new areas, it's very expensive, it's very challenging. The Tufts Center for Drug Development pegs the cost for developing a new medicine at $2.6 billion is the latest estimate. And then we also have certain market failures or inefficiencies where the way things have evolved, maybe they didn't pan out the way that we had anticipated, and we have access problems and disparities that we've got to address. So there's, given this backdrop, and again, I'm really kind of talking to experts in the room, but we've got to figure out a way to sustainably scale some of the fixes that we need beyond just a small pilot phase to address some of these broader issues. So one thing I think about a lot as a futurist, and previously I was a chief strategy officer. It's a big company, 40,000 employees. We serve millions of patients each year. I think a lot about how do we harness ingenuity of private sector entrepreneurial innovation and channel that to make sure that everyone can have affordable and equitable access. I think about that a lot. And the conclusion that I've come to, along with many of my colleagues, is we don't just need new businesses, but we need new business structures to help grow these businesses in a way to deliver this. So in my younger years, I used to do a lot of rock climbing, okay? And so this is like a sport climbing, and it's really sport climbing. It's really about power moves. And so the climbs are relatively short, maybe more like 50 or 60 feet. And so many times it's characterized by overhanging cliffs, and it's just about, a few crux moves, and you power through it. Now, there's another type of climbing called trad climbing. And instead of 50 or 60 feet climbs, these are 500 to 600 feet. And instead of just a few power moves, it's about these long crack systems. And instead of just, it's more of a pull-ups, it's more about you cram your hand in the crack, you turn it sideways until it gets stuck, and you pull on it. Okay? So it's more of an endurance activity. It's more about a pain. God, there's a lot more pain involved. When you get the technique down, it's pretty good. So this is typical of the southwestern part of the state of Utah where I live now. And this is in the northern start. This actually climb, I did this climb. This isn't me, but I've done this exact climb. It's on the question mark wall. One little quick side story. As you wedge your feet and your hands in, to push on it, sometimes you do a maybe even too good of a job. So we were getting ready. We were training to climb some other big walls in Yosemite. And we got a little anxious to where like it had been raining and sometimes the cracks are wet, but we were just anxious to keep climbing. And so I was up on a climb about a mile or so away from this one here. And I had my feet and my hands wedged in, and my hands slipped out because it was wet in the crack, and my foot did not. And so I got flipped upside down, and I snapped my ankle on the rock. I'm fine. It's all good. But, sometimes when you're taking on new things, it takes risks. And I've never been afraid to take risks, particularly when people really need it. May crack a bone, may twist an ankle, but in the end, the work that we're doing within the area of public health, broader healthcare, people need stuff. And we have to find some new paths to make it happen. So just within climbing, techniques are different, the time frames are different, tools are different. And in solving some of these like most pervasive and like wicked problems, I think instead of just trying to apply the same techniques and tools and thinking it's going to happen in the same short time frame, we need to think about solving these problems differently. Different techniques, using different tools or different business models, and having a horizon that might be longer than just 3 to 5 years. Some of the key differences in healthcare, different than other industries, is many times we're not talking about just a consumer preference item. Like, I have a couple teenagers at home, and, which streaming service do we need to use, right? Like, is this a Netflix? Is this Disney Plus? Like, that's not what we're talking about if something goes wrong in healthcare. These are like essential services, and they're life-sustaining. And when something gets messed up, it's not just an inconvenience. People get hurt and people die. Okay? There's high stakes. And as an organization, when you mess it up, you get sued. So there's high risks involved, and the complexity is real. And dealing with third-party reimbursement and insurance networks and government regulations and licensure, if you switch away from one offering to another, it may not be a quick switch back. You can't just try it and the next day change your mind and go back. Like, for instance, in the PBM business, the average RFP is 1,500 questions, and the average time to switch PBMs is 2 years. So, and many times in healthcare, it takes 18 to 24 months to even get something in. And then once it's there, it takes a while to figure it out and then evaluate it. So your actual shots on goal are measured in like 2 to 4 years. So when you're dealing with an environment where you have your pace of iteration is measured in years instead of days or weeks, it's a fundamentally different innovation paradigm you have to work with. And what we're going to talk about this other piece also with institutions. While there ultimately is patients that have that choice, many times the option set, what's paid for, what's in network, what's covered, is an institutional choice. And so one thing we're going to talk about of how to do massive scale collaboration is a term that we really kind of coined and using in this context called disruptive collaboration. So many of you might be familiar with the business work of Clayton Christensen. So about disruptive innovation. So Clay was on our board when I was at Intermountain, and Clay was an advisor to us when we were setting up Civica. And disruptive innovation is, you have a new technology or a new process that starts off maybe not as good, but it has a huge improvement trajectory to grow over time. In the case of disruptive collaboration, it's not necessarily about having a new product, but it's having a new way you work together, a new way to collaborate to deliver even existing products, but you do so at a massive scale. Because again, when you're dealing with these big problems, you have to have institutions on board to get to scale. because it takes a long time to aggregate enough patients or members to actually make the amount of capital investments you need to make to change the game. Okay, we're going to unpack this a little bit. So one thing that we think about when you're trying to change these big institutional problems is this notion of a disruption-resistant paradox. So if you're trying to change something in healthcare, let's say compared to like a functional oligopoly, like the dialysis, there's 2 firms that control 80% of the market in the whole industry, okay? Or electronic medical records, or pick your function where you have a handful of firms that control the majority of the entire market. Any one healthcare entity or municipality or medical school in isolation is small relative to that functional oligopolist kind of structure. But at the same time, you're a big, complicated organization. At SSM Health, we have 40,000 people that work there. So if someone comes out and they're like, hey, I stood up a business out of my garage with a couple of my friends, and by the way, I know you're in a high-risk environment, take a chance on me. It's hard. So as an organization, compared to the systemic failure, one organization is relatively small compared to the systemic problem. But to a brand new entity with a handful of people in it, your organization is relatively large. And guess what happens more often than not? Nothing. We get the same thing we always get. We have a lot of people trying, we have very few people making it through, and we, by and large, get what we've always gotten. How do we get something different? How do we get something better than what we've already always had? So thinking about this notion of making a distinguishing between novel product innovation and intentional democratization is where we're going to get. So when you're thinking about novel product innovation, you don't know what's going to work. And so you want to have a lot of different attempts at figuring out what is going to work. Thinking of it as multiple shots on goal, and one of the primary risk reduction strategies is diversification. You know, Josh from Yale Ventures knows this well, so you have got to have a lot of different shots on goal, okay? Now, when we're thinking about things that maybe we don't need a new product, maybe we just need to figure out how to get the water to the end of the row. And really what we need is more of a ubiquitous access profile to this. So it's about taking a single selective shot on goal, and instead of the primary risk reduction strategy being diversification, it's standardization. It's an inverse approach. They're both forms of innovation. And we need this type of innovation to break boundaries. We need this type of innovation to say, what is possible? We need this type of innovation to say, this case was proven 30 years ago. How do we get it everywhere? What's the depressing statistic where it's like it takes like 17 years for like a best practice to permeate? Well, what we have in the industry, both in public health, healthcare delivery, financing, is we have a massive amount of non-value added differentiation. Everyone's a snowflake. And as a result, we don't scale stuff that we know works. I'm talking with experts who could probably tell me the science that says, if we did this process this way, based on science, thousands of more people would still be alive today. And yet we have a hard time scaling it because there's a lot, again, every single approach is different. Where are the areas where we can do the things that are new and do a lot of them, and then the things that are old, get together and make it happen in a way that's sustainable and scalable and cost effective. That's what we're talking about, a different dynamic of that scaling innovation. An example within pharmaceuticals. So I have a colleague at Cambridge. His name is Don Drakeman. He was the CEO of the biotech company that commercialized Humira. Okay? So, and the scientist behind this won the Nobel Prize in medicine. Okay? So he wrote a book recently called From Breakthrough to Blockbuster. If you ever want to get an overview on the biotech industry, this is a great book. It's basically written for people that say, tell me how the biotech industry works. And one of the key main findings that he really articulates is when you look at developing new medicines, the biotech industry, which took a lot of entrepreneurial companies, in fact, in any one given period, there's like 5,000 different biotech companies out there. They produced way more clinical trials and fundamentally produced a comparable number of new molecular entities, NMEs, at about 40% of the cost of big pharma. So in terms of like developing a new drug, by having a really broader funnel and a lot of entrepreneurs that were like really focused, they were able to create things that were new at a dramatically lower rate of spend than the traditional big kind of like really committee heavy process. Because the majority of dollars spent on drug development is for stuff that doesn't work. Okay? But then when we think about, what about when it's not about creating something new, it's just about sustaining something that's old? You know, a big problem that we were running into was access for essential medications. These are like basic medications like daptomycin, vancomycin, the medicine to do like muscle relaxants, to give, like insert a trachea or a chest tube. And we couldn't get them. In fact, and this problem's been getting worse, and it was getting worse before COVID. So in any one given quarter, we have 250 plus medicines that we can't really even get. Okay? Not because they haven't been invented, because they're not being invested in. And the supply chain got fragile. So, and again, there's also, Martin Shkreli and the opportunism where there was a dare prim. He changed the price of one drug 5,400% in a single day. It was bad behavior. So, but when I think about this problem, one, you're trying to create the new, and the other, you're trying to democratize the old. We said, what are we going to do about this? And the standard business model of like maybe going out and garnering some venture capital for this problem was unlikely to work. It's like, okay, Josh, tell me if this is a good investment thesis, okay? Hey, there's these really super cheap drugs that sell for like under $1, and we want to raise a bunch of private capital to enter a game where we're going to compete against the largest producers of these drugs in the world, and we're going to get crushed from like that perspective. Can I have a bunch of private capital? Probably unlikely. Agree with that? Okay. Probably unlikely. So what we did is we said, who really cares in this moment that they have to have these drugs? Not just to make an excess return, but to deliver on their core fundamental business of taking care of patients when they need them. That's what we wanted to do. In the case of CivicRx, the idea of this concept of what we call a healthcare utility. We view these healthcare utilities as like a new type of business, a new business genre, is to inject a new type of entity into the marketplace that operates under a different incentive, which we'll talk about in a second, and aggregate up who the key players are that already have the demand and the interest and the populations that need to be served. In the case of Civica, we aggregated up hospitals. Within 2 years, we had contracts and had aggregated a third of all hospital inpatient capacity in the entire United States to address an essential generic medicine access problem. We'll talk about why we did that in customers. Then when we said, well, can we do this more broadly, even not just to hospitalized populations, but populations writ large? We formed a company called Civica Script. Within less than 18 months, we aggregated covered populations, Medicaid, Medicare Advantage, commercial, 140 million people. Okay? It's like 43% of the US population within less than 18 months. With partnering with over 23 different insurance companies to say, we need to aggregate that demand, the customer membership structure, and then start to apply some of these principles of lowest sustainable cost and most dependable access points. So within Civica, we were producing inpatient generic drugs. Within Civica Script, the first drug we produced here was a drug called abiraterone, which is used to treat prostate cancer. Someone on Medicare Part D plan, so a drug plan covered by Medicare, the average cost prior to us entering this market was $3,000 per month. This isn't a patented drug. Like, it's off patent. It's old. We sell it for under $200. Okay? By restructuring the business and moving it into more of an access maximization and an equity fueling type of business instead of necessarily a profit maximizing business in this regard, we were able to deliver this in a fundamentally different way. I'm not anti for-profit businesses. I think they're critical when they're developing new and novel technologies. The question is, what about when something is not new and novel? What do we do then? Here's the Cliff Notes version of how these businesses as utilities work. And I've boiled it down to 4 quadrants. Number 1, nobody owns these businesses. So I'm one of the founders. I'm on the board. This is how much I get paid just for this company. They're governed by stewards. Those stewards are institutions who are the customers of the product of this business. We also have philanthropists. When we started the business, we went out and raised $100 million, $70 million from institutional customers, $30 million from philanthropists. Fast forward, we just clipped over the 5-year mark in September. Fast forward, Civica and Civica Script now collectively, we've raised over $600 million. Okay? Government funding, philanthropy, private sector. So we were coalescing and bringing multiple institutional groups both from the private sector, again, from the government, and philanthropists to the table. And we have philanthropists directly on the board of the entities. That helps us prevent the entity like saying, hey, changed our mind, we want to become a for-profit entity now. We have governance mechanisms in place to make sure that doesn't happen. Second, the financing. We raised financing by the same people who are the customers. We did this so then as the business scales, instead of saying, hey, maybe we should raise prices because the customers are the ones financing the business, they're like, hey, how about we reduce prices? Because the institutions that are making it are buying it. And if they can buy it for cheaper, then they can sell it for cheaper. Make sense? The reason we call these utilities, and there's some people that sometimes like, I love the concept. I hate the name utility. I'm like, great, come up with a better name. If someone comes up with a better name, send it over. I'm a finance and operations healthcare strategist. I'm not a marketing professional. Help us out. But the reason we call it a utility is because in this case, we charge everyone the exact same transparent price. What we don't go and do is we don't say, I can get a little bit more out of you and a little bit more out of you and a little bit more. You're like, listen, this is our cost of operation. We're scaling it up. Everyone comes in. The more scale we get, the cheaper we can charge, and everyone gets the same transparent price. Because access to these drugs was not about creating competitive advantage. It was a pre-competitive condition. It was about creating essential access that everyone said, solving this problem together is more important than solving it a little better than them. It was a systemic problem that we needed to address. And then lastly, they operate in the market. And then that scale, because of the way that it's governed, financed, priced out, and contracted, that scale can translate to low and affordable sustainable costs. And one of the reasons why we could also scale so fast is because they're like, well, how do I know I'm getting a good deal? Right? You're getting the exact same deal as Mayo and Intermountain and HCA, everybody. Everyone gets the same deal. So it scaled just really super fast. And again, so there's a paper where we talk about this in more detail. If anyone wants to read it, just Google my name and Disruptive Collaboration or Healthcare Utilities. And I want to take actually my hat off to New England Journal of Medicine, Catalyst. Once they saw what we were doing, they said, we'll publish it, but we're going to put it in front of the paywall so everybody can get it, because they thought that it was important to continue to share this message. So, all right. So I've referenced some of these things. We've got over 55 health systems, over a third of the U.S. beds. When we were first starting this business, we thought it was going to take us 4 to 5 years to get to 4 to 5 drugs. We're now well over 85 drugs. And the reason was by aggregating the demand. So when we launched this business, we literally had aggregated 500 hospitals day one. Boom. We hit the market huge. And so that it gave us the scale economies. But what was interesting is once we aggregated that scale, we realized that people had access to these licenses to create a new medicine. You actually have to have like this full scale FDA approval. To produce a generic drug, you have to have what's called an ANDA, an abbreviated new drug application. And people already had them, but they weren't using them because they couldn't break into the market. They were squeezed out. Because we entered with such scale, we could actually bring existing ANDAs back into use and supply the market with medications without having to develop everything ourselves. No one owns it. And again, this is a picture of the now existing, our facility in Petersburg, Virginia, where we also supply the Strategic National Stockpile. And during COVID, I want to mention, I'm talking to the people who are like literally saving millions of people's lives in this room and everything you did during the COVID-19 pandemic. We had organizations that when there was needs, like some of these medications to treat people actively with COVID, they had just like these waves were just crushing different regions at different times. Again, Megan's she's the expert. It was like every time I was like watching CNN, I would see my friend Megan up there, and you're just courageous for everything that you did. And we all appreciate it so much. I really mean that. We had people donating products that they knew could get exactly where they needed to go because of our network, and they donated millions of dollars of products through Civica that we distributed basically throughout the country. And as we saw this, and as the federal government said, hey, thinking about big international tensions, how do we start to secure essential access to medications? We're working with people who are doing novel forms of API development, active pharmaceutical ingredient, and we have this unique kind of triangle of drug supply security in an equitable and low-cost way that we're building in Virginia as part of that. So it was a great idea. It worked really well in terms of it grew, it raised money, it had impact. Civica RX to date, those medications have been used to treat over 62 million patients to date. And we wanted to say, how's it working empirically? We see the impact, we see the good. Talk to us more. So we went out and did a full detailed research profile. This is why I just love the intersection between industry and high-end academics, because I just think there's magic there in that intersection. And we worked with our partners at Cambridge, and we put together a full research study, and we looked at every single of these drugs where we had major longitudinal history about what happened with the pricing, how much were we ordering, how much were we fulfilling, and this is more of an eye chart, but during the heat of the pandemic, we were still able to deliver medicine when we were getting shorted over 30% from many traditional suppliers. It was a major, major problem. Again, access was huge of how we had to figure this out. I don't have time to go through all of the data, but I do want to go through this. So we asked two questions. One, are we really improving access? And one of the things that we did in Civica was we institutionally said we're going to carry 6 months of product inventory centrally to help avoid the hoarding problem where people snatch it up and then some group has a lot and some group doesn't have enough. And as well as to just basically if there's changes in the supply chain. So one of the reasons why we have these supply issues with these essential medicines is the price gets crushed down so low, a lot of it gets outsourced. In this case, the FDA, they weren't doing a lot of on-sites during COVID. They weren't traveling. Because they're getting back out and they find a facility and it's been, has had deficits and it gets shut down, it creates a global supply chain problem all over. So we created a 6-month buffer inventory, which we carried. And again, as a nonprofit whose primary mission was to deliver access, as members, we said, if we run out, and as these institutions, in many cases of last resort where a patient need these, we cannot run out. So we chose to carry a safety inventory. So here's the deal. Every one of these blue circles is where we had to buy the exact same drug that was produced at Civica in the exact same year. So these observations here meant there was some instances where we bought the exact same product from Civica, but we had to buy it from somewhere else, and we paid almost 18x the price. Okay, so this is the proportion of prices. Civica is the index price. Okay, this, the x-axis, is the proportion of the amount of that drug we had to buy. So in this case, we paid about 3x the Civica price, and we bought about 50% of the total product outside of it. Some had to do with availability. I don't have time to go through the nuances. With Civica, we wanted about 50% of the volume. We did not want 100%. We didn't want to crowd out other essential suppliers. We wanted to be a critical primary sourcing strategy, but not a replacement option of other sources, because we want all the supply we could get in the market. And as Civica enters and everyone has to compete, there's also there's some favorable externalities that kind of flow through in the process. But here's the critical thing. If we looked at this on just like non-volume adjusted basis, just look at the comparison between these observations, the non-Civica prices were 46% higher. Okay? Our supply chain buyers are not dumb. They buy more when it's cheap than when it's expensive. But what was so interesting was, even though we drove a pretty significant increase, like for SSM, it translated into like a 40% access increase above what we were expecting to get from Civica. And there was times where in the market, we could only buy from Civica. They were the only one that had the product. So from an access, we check the box. Okay. From a cost, even after this, our teams had to buy from 62 different non-Civica sources. And even after all that day trading, all that arbitrage, it was still cheaper to buy the product from Civica. Honestly, I could tell you I was not expecting that. So in this limited sphere, we broke the iron triangle. So the iron triangle, better access, better quality, lower cost. And typically, many times it says pick two of the three. But in this case, we got all three. And I think what we need to continue to aspire to in improving health for the public, for our patients, for society, is we can't settle on not getting all three. It's possible. Now, we're on a pretty intense crusade right now to think about where else do we go. We're doing some work within digital interoperability. It's harder because that's kind of mixing some of the models, because it's got some novel development, but it also has some common marketplace shared. Whoever owns the lexicon of how data talks together, it's going to be incredibly valuable, and we'd prefer that to be owned in an asset that can really ensure there's fluidity in the way of the data and not being extractive. But here's another classic example. In the hospital space, laundry services. Okay? Crazy, right? But yet, it's during COVID, at the same time we're trying to figure everything else, we worked with the prison system and they canceled our laundry contract with no notice. Can't change the laundry, can't really run a hospital. I think in the domain of public health, where the impact is so outsized, it's hard to imagine that a discipline has had more impact for health than public health over the past 100 years. You're scaling, you're working with everything that ranges from prevention efforts, vaccination, education, shoring up community capabilities. What is the future of some of these business models to enable large-scale, massive collaboration, to not just to do so at a whole new scale, to garner tens, if not hundreds of millions of dollars, and to deliver outcomes that are more accessible, higher quality, lower cost. Because the reality is our current system is still very much characterized by a lot of really, really high-end, costly care, because we haven't been able to figure out how to engage in some of the more essential, preventative, and sustaining interventions that are characterized and led by that domain of public health. Okay? We got to figure this out. We are building an incubator. We are getting like ideas from all over the world. Like we got contacted by the equivalent of the CDC in like Norway. And they're like, this is super cool. Can you help us think through this? Like there's all these different things. I got asked to present in Paris to about 50 physicians for the Polish Academy of Sciences, thinking about how do we do a sustainable collaboration effort. In that case, they were looking more at a prevention effort. There's a lot of these things that are untapped that we can do more. And it's about sharing and going with those ideas. I want to stop in just a few minutes and I want to take questions and we can just kind of open that up. And then I know that we'll have a chance to continue to talk about this. But as I'm ending, and again, and this is my information. If you're like, hey, I have an idea, want to talk about it, awesome. But I want to, just like how we started with a story, I want to end with a story for a second here. So I'd mentioned my mom was paralyzed. I'd mentioned she had a lot of health challenges. Before my mom passed away, I was very early in my career, relatively speaking. I was far enough along that I'm like, I'm out of graduate school. I'm leading a company. I'm a CEO of a division of about 1,300 people. And we're trying to like engage in a broad population-based strategy. And it's hard. And you know what, honestly, I was kind of calling my mom whining about it. Mom, is so hard. Like, like people don't like us moving their cheese and politics and they got to raise the money and I honestly was just whining. I'm going to share with you what my mom shared with me. Okay? She said, do you think being paralyzed is easy? Do you think being homebound is easy? And I felt about this big. But then as my mom always did, she turned it and she said, Carter, I don't really have many choices in this regard. I only can get what the system gives. I'm just a taker. That's all I am. That's all I have. She turned it around and said, Carter, you're a leader. You have knowledge, you have training, you've been educated, you have influence, you have choices. And she said, and I hope what you do is I pray that you will take your choice and your influence as a leader in healthcare and make it better for the people who have less choices than you do. And that's what I promised her that I would do. And that's what I'm going to keep doing as long as I have breath to do it. This business model, yes, it's focused on generic drugs. This business model is trying to figure out how to alleviate human suffering at a new level of scale that we need for people who have less choices than the people that are sitting here in this room. That's where I'm focused. And it's a pleasure to be here today. Keep going. Let's take some questions.
Thank you, my friend. I hope you all see a little bit about why I kind of get excited when I get to chat with Carter. So I'm going to open it up. I'll start with questions in the room, and then I'll toggle back and forth with Holly. Carter, I can let you choose kind of who you want to ask questions of. I can run around with the mics that people on Zoom can hear.
Thank you.
Oh, yes.
Yes, sir.
I just like to keep our Zoom colleagues engaged,
Thank you. It was a great talk. Why do you think this model is more successful, say, than Haven, that was supported by Buffett, Bezos, Jimmy Dimon, and had a huge amount of money, but they ended up shutting it down? The second question is, when you say we produce, are you a CRO or do you subcontract the production of compounds elsewhere, India, China, etc.? Just
great question. I'll take them in reverse order because I think the other one is even broader. So to start, we work with contract manufacturers to basically then we'll contract on several to then drive this. Now that we're finishing up our essential medicines facility in Virginia, we'll actually do direct production for some of those essential medicines. So started with largely a contracting function to test the model, test the market, aggregate demand. and then we're moving into, and we'll still engage in contracting in several of those things, but there'll be some that we will be able to produce even at a lower cost directly within the facilities that we're producing. So we'll be a direct manufacturer in that regard. Second, why did it work and why didn't some of the others? So I had a colleague from Cambridge that was actually inside of Haven when it kind of imploded. But there's a couple things here. So one, and there's several different reasons, like in any business. Now, one thing, Amazon, once they kind of figured out what it was, they could kind of do some of the things on themselves. So to some extent, it was a three, with JP Morgan, Amazon, Berkshire Hathaway, there was still to some extent three strategies in that element. What I'd say is when you think about the structure, one, if you're trying to change an insurance profile, Amazon, one of the largest companies in the world, all of them actually were really large, but actually in the insurance business, 1 million or 2 lives on an insurance play from a risk-bearing entity is really small. So I don't think they reach terminal velocity of scale. And I think when you think about a business model, in this case, the way people could join and really get to that critical mass of scale was very transparent. And also this problem, I would just be honest, it's probably easier. This was an easier, more direct problem than solving an entire healthcare spend, curbing the healthcare spend trajectory problem. So when I think about healthcare and solving these problems, if we think about, again, with everything from public health insurance, hospitals, et cetera, it's a massive ball of yarn. Massive. And what are those strands that we could take and pull one through and then set it aside and let it continue to do its business? Pull it out, set it aside. So in this case, I think it was a more concrete problem. I think there was a clear ability to manage the distribution. And we did reach a critical mass of scale on that segment faster than the others. And that's maybe just a compare and a contrast of what I would say. But it's certainly not about like one group's smarter than the other. I think it's a different type of problem and a lot of complexities.
Which is, I think, as any researcher in this room will know, defining the problem before you start is the key to a successful project. I'm going to read a question that was online, okay, which is from one of our colleagues who was unable to be here today. Can you talk a little bit more about how you're thinking about applying this healthcare utility model to digital health?
Yeah. So we think in terms of the creation of digital solutions, we think will come from literally thousands of different companies. So we're not viewing this innovation related to like, how do we create the company that creates lots of companies? We're thinking of saying, what's the piping in digital health that needs to happen? Right now, a majority of digital companies, a majority of their capital is still spending on doing a lot of time accessing data and just getting up and running. We call it the adoption gauntlet. The adoption gauntlet of a digital innovation in a healthcare setting that has complexity, HIPAA, business associate agreements, it's 12 to 18 months just to get in. And everyone basically carves their own slice. They do all their custom data normalization and aggregation. And guess what? Then they go to another client and they do it all over again. So the thing that we have is to say, how do we start to create an infrastructural play? We call it a graphite standard. We think about moving into digital. We call it the digital Hippocratic Oath of how do you have a modern way to create, again, a lingua franca that has enough interoperability that allows for multiple digital players to engage in that in a much more efficient way. So saying, how do we create the pipes? Just like a utility example. How do you build the electrical grid? Just like a utility example that enables a massive proliferation of digital new entrants.
Thank you. We'll go here and then I'll go back to Zoom. And I should have asked you all to introduce yourselves also so that Carter knows who's asking the questions.
Thanks, Megan. Luke Davis. Thanks for explaining the market problem. I think many in this room will have appreciated that. I'm interested in global health, as many people are here, and the issue of developing novel and effective technologies and especially therapies kind of for neglected tropical diseases, non-communicable diseases, which is a big one now. I'm just curious, you mentioned that you're thinking about this for the global marketplace. How would that kind of differ from what you've done here, and how would you think about approaching those problems as a good fit for those problems? Thanks.
Oh, that's an excellent question. I'll do as best justice as I can on this. So one thing we're actually talking about is in some of these other developing countries or markets, we're we've been approached actually by some people representing countries in Africa of saying, could you actually think of the unit? In this case, the institutional customer was a large corporation. You potentially could start to think about what that institutional customer could actually be a country. So an innovation center in Scotland is worried about actually there's certain countries and in parts, particularly like Eastern Europe and other places, they don't actually even get access to many things because it's like the juice isn't worth the squeeze from the corporations to say, I'm not going to go through all the hoops for just a small fraction of the population. So is there a way that we could start to create a scalable collaborative that actually can pool this together so that, again, what application? I don't know yet. We're actually doing some work, and I can't talk a lot about it, related to certain types of cancer treatments that are well established that we're trying to introduce into different parts of the world. Other kind of essential infrastructure. There's some interesting people and conversations we were having related to cataract and blindness work, like with the group Aravind out of southern India that's done incredible work. They basically almost have like vision coverage for like the 7 million people in their little province, and pretty amazing. And so we're exploring different avenues. I'd say still very early. What I would just say, that's why I spend the time kind of at least talking about some of the fundamentals and basics and why we were so big on publishing it instead of creating like a for-profit consulting company. We want to get the ideas out so that the best idea is likely not even going to come from us. It's going to come from someone else that's already spent a life and a career thinking it, and there's urgency. Where's the urgency? One last thing I will say, solving these problems is hard. And an affordability problem, while it's urgent, it doesn't have the same urgency as either access or true like kind of like physical need or harm. Because many times in insurance regimes, you can take every acute financial problem and turn it into a chronic disease. You pull it up into the premium, spread it out, stop the screaming, problem doesn't go away, it just gets diffused. When you have a real access or an urgency problem, it doesn't go away until it's actually solved. So where we have each health system ecosystem in its country or community has an urgent need. And so we really go into where the urgency is. Does that maybe get a little bit at?
Right, I'm going to do another online question, and then we'll maybe have time for this and or maybe one more. We have to be out of here in a few minutes because there is another class. Until we get that new space and classes where we don't go right up back to back. So online, a question about whether you're interested in healthcare utilities with regard to services, for example, prenatal care or mental health, as well as products such as generic drugs.
Such a good question. Lots of good questions.
We've got great people here.
I know. So I'd say, yeah. So one, even though we started in the products, we absolutely see relevance within the services space, particularly if there's like a mature evidence-based intervention that we want to scale. Now, undoubtedly, producing more drugs that you can scale, there will probably be like more of a local or regional flavor with some of the services development. You can't like instantly provide the service if it requires people like everywhere all at the same time. So we've actually spent some time. We have several services that I can't talk about explicitly under NDA, but what I'd say is, can it apply to services? The short answer is yes. Can you think about how to scale those services in a way where you have critical mass and locality? Yes. And even thinking again about something as simple, I talk about it just because it's not under NDA, because we're doing it with this laundry services collaborative. We're basically putting the infrastructure in the disadvantaged kind of zip codes to actually bring jobs into that same area. And laundry service is a high freight intensive service that's largely going to operate local, but it was beyond the scale of any one collective player. So when you think about a lot of these like anchor networks that are getting established, we think that actually marrying a utility construct to an anchor institution infrastructure in both products and services is doable.
And I will challenge us all to think about how we can apply that to public health. So I'm going to close here just for the sake of time. Carter will be sticking around, so come on out and feel free to chat. He has his information here. I do want to, here at Yale, we are big on swag, and so we want to thank you with a little swag bag for you.
Thank you.
Thank you.
And you guys know we also do swag for you all. So you know the drill at this point. Look under your chair. There's somebody who has some special treats. I think we have 3. 5. So if we're looking for 5, look under your chairs. Get a little Leaders in Public Health bit of swag for all of you as well. Thank you. Go enjoy your day.
And I would just say this. Thank you for what you're doing. It matters. Thank you, thank you, thank you for what you're doing.